Good evening, friends, and it is again the 10th of the month, 10th July, 8 p.m. And I'm back again as the Chairperson, Imaging Science Committee, FOGSI, to present yet another impressive guest on my podcast, the Gyan Pravah, and we have none other than Dr. Mohan Kamath. But before we really go on to the podcast, let me welcome my dear friend and President FOGSI, Dr. Sunita Tandulwadkar, under whose leadership and dynamism we are moving ahead on the Gyan Pravah, creating wisdom, gaining wisdom, and creating value for FOGSI. So welcome, Dr. Sunita, and over to you.
Thank you, Nina. Thank you so much. And thank you, Mohan. Thank you for coming on a FOGSI platform.
Thank you.
It's lovely to be. We pulled Nina from infertility into FOGSI. Same, we are getting you on a FOGSI platform. And I'm sure this podcast will be one of the amazing podcasts we have. So, Mohan, every day at 8 p.m., we have 30 chairpersons. So 30 days, 30 people have been given. So it's a 10th every month. On 10th, Nina will be there with any faculty, maybe from academic, non-academic, any inspirational personalities. And we have now interesting discussion. Believe me, I thought just doing something differently for our chairperson, who are our future leaders of FOGSI. But now, today is what, Nina, 170th?
Yes, 170th.
178th. And I have met every day 170 personalities. You evolve. So much people are doing. There is so much more in this world which is there. And definitely more than my chairperson, it helped me probably. So, Nina, I'm sure your podcast is going to be one of the fantabulous podcasts. Mohan, not only great academician, but the great orator as well. Our protocol is, Mohan, after she introduces you, I join the viewers link and you both will be having the dialogue with each other.
Thank you, ma'am. It's a pleasure being on this platform. Thank you.
Thank you. Back to you, Nina.
Thank you so much. So I have the good fortune to have with me a very dear friend and a researcher par excellence, Professor Mohan Kamath. To some who knew him and to a lot who will know him more through this podcast, I do my honors by introducing him. He is the head of reproductive medicine at the prestigious Christian Medical College, Vellore. He has risen to the ranks of a professor not just by his talent, but also has lately added many feathers to his crown, including a master's degree in clinical trials from the University College London. Mohan brings with him experience, clinical, academics, and on the research field far beyond boundaries. He's made us proud by his publications, his work, and his contribution to the Cochrane Library, which he avidly writes for, on all aspects, clinical, as well as many more on reproductive medicine. So welcome, Dr. Mohan, to this podcast on IVF success. Is it the oocyte numbers that matter? So before we really, spill the wall.
My dear all, enjoy the dialogue and it will be wonderful to listen.
Thank you, Sunita. So before we really start shooting questions and take opinions from Dr. Mohan, just briefing a bit on our subject. Today, I think over 12 million babies have been born out of IVF. Seem like a boon to childless couples ever since Louis Brown was born. Today, we have everything to sort of go ahead with IVF technology, which we never thought could be available at the tip of a click of a finger. We have gizmos beyond our imaginations. We have a society which really expects so much from us. Yet, I think we have not lived up to the expectations because humbly still, if we look at the HFA database or the database from the American side, the SAR database, we are still stumbling at the best percentage of live births around 45 to 50 in the best of units. So many more challenges that we see. So to discuss on the very many aspects of IVF, I have Dr. Mohan Kamath. So Mohan, I am sure you will agree that in the last 25 years, India on the horizon of ART IVF has made great strides. And when I was looking up numbers of the more than 12 million babies born, 8 million babies come from India. That's really impressive. So an industry which I think is really going to make a mark in the next 10 years, at least from the Indian side of the business. So when we look at it, do you think the numbers are the same in terms of, the success numbers that I quote? Are they going to be better with the gizmos, or you say, yeah, it doesn't make, it is the patient factors that make an impact on our IVF success?
So thank you, Dr. Nina. I think overall, I think the land is probably the same. I don't think the gizmos are immediately right now, at least let's say a last decade or so. I think it's just the cryopreservation or the freezing protocols and the ability to freeze and make it more safer has been the most, I think, the landmark change in practice. So if you just step back, I think 2 decades back and all, we were not so confident about cryopreservation techniques. And we ended up using a lot of long agonist protocol. But I think the landmark change happened because the introduction of antag and antagonist protocols and cryopreservation going together. And we started becoming, I think, a lot more aggressive in terms of stimulation. And ultimately, I think the results have improved a bit. But as you said, we are still far away from what our patients expect. It's still probably, I would say, 35, 40%. Cumulative going to 50% is where we are. The gizmos, I think so many new things are coming up in the lab, and that always excites us because I think you and me would agree that most of the things that we expect will come from the lab. There's not much that as clinicians we have in hand. I'm sure you would agree that apart from choosing patients and using protocols and tweaking the doses, a lot happens in the lab, and rightly so. All the newer technologies are mainly in the lab. But I think with the AI coming in, and as you know, it's been the hot topic in X-ray also. I think we are in for interesting times. Our ability to probably identify the potentially viable embryo will be much better with less of invasiveness like PGT and so on. So I think interesting times ahead in the next 5 years. I think we'll be there in the next 5 years where we'll be able to probably zoom into the embryo and go for more single embryo transfer, the way I look at it. Yeah.
So I think I'm just going to, since we've set the ball rolling, I think we are warming up. I would say, do you think there are factors in today's day? Yeah, we're reading and we read. Do you think there are, I want you to reiterate, what are truly the factors which still say, yeah, they are very important to predict our IVF outcome, and there are some impediments to those factors. So could you sort of allude on those
yeah, so I
issues?
think for single, the two things that I think you and me would agree, of course, there are more. First, I think is the age factor. The female partner's age is always on our mind. So anybody who's beyond 35 we know that the rates start going down across, and the aneuploidy rates go up and so on. And of course, the oocyte number, that's what we are going to discuss more in depth. Then, of course, it's all about the reason why IVF is being done. It could be a severe endometriosis, and then it again impacts if there's a very severe male factor, you're getting sperms only from testis non-obstructive azoospermia, which all starts, impacting in some ways. But broad two pillars, and the third coming in as an indication. But broadly, it will be the age and the ovarian reserve, which is where we all are always, stuck. We know that which way the woman is likely to respond. And then third down the list comes the indication. So that's where we are. And those are the main predictors, I would say, at this point.
Yeah. So yeah, I think we are going to move forward to our topic, which is do the oocyte numbers matter? But I think you rightly said that in the last decade or so, we've almost understood our stimulation protocols better. We're kind of doing a personalized kind of or individualized approach to when we stimulate. So do you think that the oocyte quality or quantity matters? With the quantity versus the quality. And when you look at it, do you think, yeah, there are some ovarian reserve tests or some ovarian risk markers which really say, yeah, we will rely upon them, call upon them, and they would be able to tell us, yeah, it's not just quantity, but it's also quality that comes from there. How do you feel about the literature that's available and your experience, of course.
Yeah, so I feel it's of course quantity we know is about over and reserve, and quality is more linked with age, and we know that there's only a finite number of sites and the best. And in fact, to put some light on this time the Eshrei keynote by Sebastian Maston Group was on oocyte aging in some way. The landmark work that they have shown in terms of the oocytes that they retrieve from older women and what are the problems and so on and so forth. So that remains to be, that's something that is standard. We all know that oocyte number is over in reserve and quality is linked to age, and there's an interplay between them. But I think the issue starts becoming more difficult when the cases become difficult when you have less numbers and the oocyte quality, of course, is down. And that typically happens when we are looking at advanced maternal age. But if you have a larger cohort of oocytes, you always will get away with it. That's what I have over the years observed, and that's what probably we'll be focusing on. And it always helps to have a larger cohort of oocytes because at fag end, of course, you'll have some oocytes with some abnormality. And one thing that probably is worth discussing is we do have this so-called oocyte quality based on what our embryologists say, but there are very limited number of actual oocyte abnormalities which is there in the the Vienna consensus and so on. The rest of it is, to my whatever understanding, is a bit subjective. Many times people say, okay, there is a large vitelline space and so on and so forth, but you get very nice embryos out of it in pregnancies and so on. So they're not very predictive. So sometimes there is a element of subjectiveness, I would call it, regarding the oocyte quality. But yes, as the age factor goes in, we know it will impact at some point. So overall, I feel oocyte numbers, and there's an interplay. But if you have good numbers, you will still be able to ride over the quality issues because you have a larger cohort of embryos and you can select. That's where I think, but both of them are important at some point.
Yeah, I think you rightly pointed. It is the quantity which offsets the quality also. So we get out of the big bunch, we may be able to choose. So certainly, we ovaries in Indian women age ahead of their counterparts. And I think women in India have age matched to their Caucasians or Western or developed countries, lower ovarian reserves. I think we all have data, we all have our experience. But then we are looking at some number. I know when we talk to our patients in today's day and age, when there is a Dr. Google guiding them, we still have to. But let's look at our experience. Let's look at evidence. Now, where do you think we would say that, yeah, is there something called a target number of oocytes, which we feel, yes, that target number should be there, which will maximize our success, which will maximize the outcome, and look at, say, a better live birth rates. How do you say about that?
Yeah, so Dr. Meena, I think this has been an interesting journey for us. I think past 2 decades, if I sum up, when we were getting trained, at that point, we were quite happy to get around 7 to 10 oocytes, and we felt this is fine. I think probably which was a safety also, we didn't have the antag and the agonist triggers and so on and so forth, and freezing wasn't so great. So getting 10 oocytes was like, okay, we've done it. Then, of course, the landmark paper by Shesh, Kamal, and other group from HGFA, we started saying that, okay, the target is 15 and you get good results up to 15 and it plateaus off. But then there was a build up from there, and then they figured out that 15 is a magic number for per cycle. But if you're looking at cumulative live birth, you can go a little further. You can go up to 20 and then it kind of plateaus off. So now when we go around, I think that's a paradigm shift, as I would call it, in our simulation protocol, that, as I already mentioned initially, we are a little more aggressive. So earlier we were happy with 10 to 12. Now we are happy if we fall between 15 to 20. But then, of course, we don't have that control. You can't really target 15, 20 and expect to stop at that. Sometimes things do get a little more than what you want. You might get 25, 30, and that's the problem that we really need to work around, because getting too many also isn't good for the patient. Morbidity is more. You'll end up with torsion or ovarian hyperstimulation if things don't work out well. But as of now, if you ask me, looking at the cumulative live births, we would target between 15 to 20, more towards 20, but I'm happy to get 15. But of course, then it's our lab which will deliver us, even with slightly lower number. If we have a good lab with good culture conditions, we should be able to get decent number of blastocysts and move on. Yeah.
But yes, I would totally agree with what you say and the data which comes from, HFA. But realistically, I think in the years that I've seen of training and doing, I think reaching the magical double-digit numbers also seem to be a little of a difficult number to chase because, for the kind of women we see in our day and age, even a normal responder, I feel surprised if I reach 11 or 12 because I think we are still chasing that double-digit are far too difficult. How do you feel about that in your because we're
Yeah.
coming from the south versus the north? I mean, somewhere do you feel, is it mattering and is it a cause of concern to you in terms of the
I
theoretical so-called HFEA numbers versus our numbers, or should we have our own numbers to say what is the number needed to achieve a pregnancy from the Indian sort of perspective and from the Indian
Yeah,
side of
great point, Dr. Nina. Actually, we have observed this, and this is something which is bothering me as well, that our mean gonadotropin usage per patient has gone up. Okay, so now I find most of my patients are at 300. As long as they are not having polycystic ovarian morphology, they end up somewhere between 250 to 300. And yes, we are not able to get that magic figure of, let's say 10, 12, we get it, but 15 and all is not easy, even with pretty high dose. And probably, as you said, there's something going on. We are seeing a lot of patients with lower AMH for some reason. Last 4-5 years, and especially last couple of years, we have been finding a lot of patients with lower ovarian reserve. And yes, rightly, even we haven't observed reaching 15 is an easy task. And unless the lady is young, less than 25, or a polycystic ovary, AMH is 3, 3.5, you talk around bordering PCOM. But otherwise, yes, I think if you are happy, you get around 12. And as I said, if your lab is able to deliver with that, it's great. But yes, there is a shift from what others are seeing across probably, the Caucasian race, something, but we haven't been able to get that numbers as well. And there is something that probably needs more investigation and focus. Yeah.
Yeah, to my viewers, I just thought I would just interject and say I missed on introducing Dr. Mohan, who is a lead in a lot of clinical trials along with me. We do a lot of trials, including the IPOS and MIMIT. And I think, Mohan, while we are doing the augmented or the artificial intelligence project together, maybe that is the way where we can pool our data and say what is the number we get, because 2 units in public
Yeah.
settings, we would probably be able to sort of look at some data where I feel we need to sort of look at what is the minimum number that we got, or for that matter, what is the target numbers that we look. So coming back here, and coming back, do you think there is again a minimum number of eggs that you should look at, a oocyte that you should retrieve to get at least one euploid embryo or one euploid blastocyst? Because at the end of the day, you want a singleton live birth. We are now scared of getting to have multiples or twins. So do you think we still have reached with our intelligence, which is not artificial, but it is augmented, to say, yeah, there is a number which says, yeah, that's something which would be happier to say can give us, of course, keeping age in mind, and that's important when we get patients.
See, the thing is, of course, we don't have PGT, so I don't have personal experience on seeing, how many would land up, how many oocytes give us one euploid. But of course, literature is very clear that you get around 11 to 12 oocytes and you get one euploid blastocyst. But for all those who are not having PGT, if you and me would like to discuss a sustained implantation rate of 95%, that is almost majority of women conceiving and carrying on with the clinical pregnancy, the magic number is around 4 blastocysts for women less than 35. Now, this is, of course, data coming from US and the RIF consensus. So I would think that you and me, if we look at stimulation, our goal should be to get at least 3 to 4 blastocysts, but it's easier said than done. And all this data probably is coming from those state-of-the-art labs, which are, doing the culture condition and so on. So it would be not easy to just extrapolate that to our labs. And as you know, periodically we have our ups and downs. The aneuploidy rates would vary according to the labs. And we should be cautious, and probably here importance of our own data would come.
Yeah. So you're right, getting to 4 or 5 euploid blastocyst is what we would sort of look at, not for a single live birth, but for saying, yeah, she can go for another birth. And rightfully, as you said, it depends a lot on age, because to reach the magical number of even 4 blastocysts in somebody who's 38 years and beyond would actually require many cycles, as against somebody who's younger to 30, or at 30 or 32, or maybe 35 as well. So that's really well said and well taken. But then, as you rightly said, even I do not have a PGTA service in my place, and we are still dependent on morphology, maybe the embryoscope that we have, and we are sort of beginning to enjoy it. But then, how many of the untested blastocysts that we are getting? Of course, some of the private units have not reached, like in America, every blastocyst is subjected to PGTA before it's actually transferred to the woman's womb. But then how many untested blastocysts are needed for maximizing the success in a woman who is lesser than 35? Because, from the numbers, where would you look at with somebody who's beyond 35? That is what I would like you to allude.
Yeah, so actually, I don't know, the RIF's consensus statement did claim less than 35. It's around 4 untested to get 95% sustained implantation. But they were presuming that the aneuploidy rate is around 20%. And as you climb up beyond 35, it becomes 5, and then it is 38 years, it becomes 6, 7, and so on. So, but they have set the aneuploidy rate at 20, 30%. We are not very sure, whether we will get 20% aneuploidy in our unit for ladies less than 35. So that number could be higher, depending upon what data we get from our center. Yeah.
So I think as we move forward, there is another important topic, which is not topic, but a common kind of scenario that we see. We talk of these numbers in terms of oocytes, and then we say numbers in terms of embryos, and then we say numbers in terms of euploid blastocysts. But to set, I think the big caveat for all of us is co-responders. You see that across the globe, we are facing this challenge. Maybe it is our environment, our genetic, reasons. So what would you see as the kind of, alarming numbers that you see in co-responders? Where would you say that, yes, this ovarian reserve marker is really foolproof for me and I would fall back? We know we have AMH, AFC, but between the two, if you were to say, yeah, this cracks my code, where would you sort of put your finger on when you are deciding on, say, I'm not talking about an unpredictable corresponder, but it's a predictable corresponder. Where would you tilt the balance to?
See, I rely on both because both have their own utility, but I end up trusting more when I'm closer to the cycle. When I'm initiating, I'll trust more the AFC, the antral follicle count, when I'm right there starting stimulation, just to decide the dose. But most of them, of course, will be on a high dose. But otherwise, AMH of less than 1 nanogram, of course, the cutoff is higher, 1.2, 1.3 for Poseidon. But I have seen that between 1 to 2 nanograms for AMH, the AFC could vary here and there. It could be as low as 5, 6, then otherwise it could be 10, 12. I'll be a little more reassured and reassure my patients, even if they have slightly lower AMH, but as long as the antral follicle count is around 8, 10 or beyond, and that happens many times, But once you come down below, let's say AMH of 0.5 and you're seeing an antral follicle of 2, 3, 4, that is a real concern, because then you know that even if you push harder with a lot of gonadotrophins, things are not going to go dramatically different. So if you ask me for the decision making, I'll take both. But once I'm very close to IVF and start initiating some IVF, I'll be just going on the antral follicle count on the day we start the gonadotrophin, because that's what we are actually looking at.
So we would say, yeah, decision making would be based on my dosing would be based on AFC, but how about your prognosis? And because everybody doesn't go back with a euploid blastocyst, for that matter, I would say leave alone a baby. But then would you come back and say AMH, yes, is where I would come back to?
Yeah, I would probably, that's what, as I said before, pushing the patient and talking about IVF and all, we'll use more of the AMH. If somebody's got, let's say, age is also on the higher side. Typically, when I see couple, and the lady's age is around 38 with an AMH of 0.5, I am prognosticating a live birth of 10, 15% at the best, if she lasts. But of course, if she's younger, if she's 30 and a low AMH, I still would be much more optimistic. I would raise it up because in those patients, as you know, you would still get away with lower numbers and still get in. So I'm a little more optimistic, 20-25% with a low AMH of 0.5 at age is 30 or less. But if it's age at 38, we really have to scale down and give a realistic picture to the patient. Yeah.
Yeah, I think you really, really hit the nail right. And I think as we have learned in the last decade, from 45 definitions of corresponders coming to the Bologna criteria, today we have a very patient-oriented stratification in terms of prognosticating. And to this rescue, we have the Pozoidin criteria. And I'm sure, I think it has really made a lot of impact in our better understanding of not just the predicted, but also the unpredicted corresponders. So, Mohan, where do you think that now that we are knowing Poseidon criteria and we're using it in our clinical practice, do you think it's good enough, robust, even though there are a lot of studies which are valid? Do you think it's really robust enough to say, yeah, that's it, and we don't need to think? Or do you think there is something which it doesn't encompass, especially from the Indian, perspective, from the Indian side? Or you feel, yeah, we can tweak it a little because, or does it, do you feel it defines and covers all categories of corresponders?
So I am still a little skeptical, I'm afraid, about the Poseidon, especially the one on unexpected, response, because my fundamental position is that we are just making a judgment call based on the, slightly suboptimal response or a, lower response in the first cycle. And my disagreement goes from this that, see, we have made it overtly simple to say that all the women in the world, we will start categorizing between 150, 225 or 300, and that's about it. We really don't know what's the individualized dose required before we start the first cycle. And that's where the catch is. So, and Poseidon, the 1 and 2, the unexpected groups, basically are, really coming heavy on this part that, okay, she didn't get 9 oocytes. So there's something fundamentally wrong and we start chasing it. You start looking at the FSH polymorphism and things. We've had a discussion on this. In fact, we have a study which we just finished and we are still analyzing, but I am skeptical that we'll find something very dramatic in the FSH polymorphism. I know that there are a lot of groups now educating, adding LH and so on and so forth. We looked at this data, Dr. Meena, and I must share that we published this in HR, that what we did was, and you and me do this all the time, when we don't get enough oocytes in the first trial, we just go on the higher dose, we change the protocol, and things work equally well in the second cycle. And this is what I call a performance bias in some sense, that first cycle, sometimes we don't get things right because it's always the suspense. And we do the course correction in the second cycle, provided, of course, the patient visits with us and she trusts the system. And we are a lot more careful, isn't it? You and me would, even in a busy unit, will focus more on the patient who are having repeated failures. And definitely we will then go, if I'm there, I might go and do the egg pickup myself and ensure that every bit of, the follicles are trained. So just tweaking the dose and protocols works wonders. And we did show that in one of our studies. There's really no need to make a drastic change. I would be keen to know what you feel, how far do you go?
I totally agree with you. And I feel that, yeah, Poseidon has given us better understanding. But I think coming from the north of India, I feel there is something which you may agree, disagree with me. We have a subset of women who have tuberculosis, right?
Yeah.
Where I'm looking at the variant factor. And I have data which I have seen where we know that the AMH AFC are discordant, yet we make it there. Despite their results. And I think you rightly said it's like a test drive. I took the drive and I wasn't very happy. But when I kind of wheeled up and I just ironed my things and I find, oh, this is a magnanimous vehicle that and that's exactly what we do. Because it's naivety to begin with, but you try to understand your patient factors as you move in the cycle, as you move along. So probably the mistakes or whatever understanding that patient teaches you are your lessons to improve and improvising or improving, because tweaking the dose, I don't think getting her to 450 would get me the pregnancy, but I tweak my recipe. I do a little bit and I certainly get not just numbers, but I get a better quality. So I feel it's a lot about individualized or personalized, medicine. So I think moving from the poor responders, and I think under the gamut of poor responders, we have endometriosis. And you'll certainly agree, for what we saw endometriosis while we were training ourselves today, the numbers are on the rise. Of course, there is adenomyosis that also adds to our problem. But let's look at the ovary and the numbers. So do you think when we have endometriomas or an ovarian endometriosis, um, as to fall back on your reserve markers, what would you trust here, an AMH or an AFC? Because we are doing the counting. Where do you take your understanding here?
So here, this is one of my pet topics, I would say now. I'm focusing a lot more on endometriosis, and we've had some good publication on this because, so I would say here, I would trust more the AMH because typically, as you would know that, and you would agree, that we don't see enough of antral follicle counts when the ovaries are behind the uterus and there's an endometrioma sitting there because of the shadows and everything else. It becomes a challenge to identify, and sometimes you will not know where the ovarian tissue is unless you start stimulating and you see the follicles are coming from somewhere where you didn't expect. So antral follicle count probably is not the ideal choice here. I would definitely bank a lot more on the AMH, even closer to deciding the dose. This is one place where I would. That's where, at least for your question. But yes, I would be happy to discuss about here the ongoing and a debate which has been going on for ages about oocyte quality and the uterine receptivity and so on. Yeah.
There's also papers which said that if you look at Reed in the last 10, 12 years, it said that a surgery or a endometrioma cystectomy or a removal improved the numbers. And I think it's not wrong because somewhere they weren't able to actually count those numbers because once the ones which are the tissue which was like embedded or buried behind the endometrioma has got a chance to be visualized, has a chance to be scoped, to be sort of radiographed and picked up by our probes, which was not been seen otherwise, and therefore can't say that the reserves improve because there'll definitely be some bit of a tissue injury when you do surgery. But lo and behold, it's because those AFCs were not seen. So rightfully, you just touched another, sore point here is about the quality. When poor prognosis patients, we have. But how do you rate the quality of eggs that we are getting? Of course, our embryologists are better to answer this question, but as clinicians, we are the ones who are answering this to our patients. Quality and quantity in women who are having endometriosis and undergoing IVF. Do you see, yes? Is it just the numbers which is less, or is the quality which also is different in these patients?
So, Katrina, here I have started having a different point, and of course, it's not mine alone. I think some very prominent people who are published, Eduardo Somigliana and others have also, dwelled on this. That probably it was never a quality issue; it was more of quantity. And I understand this because I looked at the literature, and the literature started coming right from 90s, where they had taken donor oocyte model and they started feeling it's the oocyte quality. But you would agree that what happens typically in patients who are undergoing IVF with endometriosis, most of them would have been operated earlier, and we would always struggle to get a good yield in this group of patients. So we have a smaller cohort. And what happens is whatever is there, we give it to the embryologist. And obviously with the smaller cohort, there'll be a part of it which will not be good. And we grown up hearing this, okay, the oocyte is discolored and the quality is not good. And yes, it's severe endometriosis. And we also tend to agree, it's severe endometriosis. Some of the follicles probably would have missed because we could not see it. It was behind the uterus, there was an endometrioma sitting, and you and me know how much, however we twist the needle, beyond a point you can't turn it around and get all the follicles. And we give up. You have to have a risk-benefit ratio. You're gonna chase that one follicle behind the endometrioma to get that just one extra yield. Somewhere the risk is just too high. So end of the day, we always had a lower yield. And it's not because endometrioma is sitting and we couldn't simply access it. And now, one of the interesting studies which came online for us was we looked at it in a different way, and I would like to know your views on this. What we did was we took women who had severe endometriosis proven by a laparoscopic cystectomy, but they had a polycystic ovary morphology, and we took a control where they had only PCOM, and we also took another group which had only endometriosis advanced but no PCOM. And what we found, but the women who had very advanced endometriosis and PCOM, their cumulative live birth was as much as those who had only PCOM. So having an advanced endometriosis did not bring down their cumulative live birth. Both were around 50-55%. So that brings, whereas the only severe endometriosis group had a very significantly lower cumulative live birth, which was expected. So our final conclusion in that study, which was published in RBM Online last month, was that, listen, we have severe endometriosis in this group, but because we got the numbers, we had the mean oocyte yield was 10 to 15, 10 to 12 in the PCOM and endometriosis group, which was almost the same as the PCOM group. You got away and you got your cumulative live birth, which was similar. So if there was an oocyte quality factor which was really influencing the live birth, it didn't really do the thing. So ultimately, what we actually learned was that suppressing what we were doing 20 years back, giving ultra-long protocol, in fact, ended up harming many of the women because you actually suppressed them so much that we didn't get the oocyte yield. So our final conclusion was, let's focus at the numbers and try to maximize by giving less of suppression, unless of course you have adenomyosis, complicated thing, which is a different subset of patient. But if it's just endometriosis, try getting the numbers and you might actually do better. So this is a fundamental shift in the way I think on this, and I thought I will get your views on it also.
Yeah, I think you rightly got, and since you published, what better way? I think we all should have a read on this, because if it's numbers were quantity versus quality, certainly, I think there's a mixed group, because there's some say the quality is not good as compared because of the so many marker influences, oxidative stress. But one thing that I have realized in my years of experiences, whatever said and done, the severity of endometriosis, age still plays a very big role. An endometrioma, which is whatever size, whatever degree, coming from a younger woman, that one embryo gives her a baby. Whereas you may have a good cohort of good embryos in a little advanced age once becomes a challenge. I'm sure your data will really say that quality doesn't matter. The quantity does matter here, because even if you get less, if you get a good quality, you're still able to convince yourself and get to have a pregnancy in a patient. Now, I know that as we started talking about two-digit oocyte numbers is getting a challenge in our kind of scenario in today's society, with women pushing their age of marriage, taking careers in advance, we will be seeing getting women at 39, 40 a norm. Let's accept it in the next 2-3 years, at least all of us are facing. So when we know that we are not reaching the two-digit number, and we know we need to get to a magical number of at least, if not 15 to 20, at least for India, 10 to 15. I think that's what I would put. Where would you sort of want to put your, tilt yourself? Would you say, let's do back to back, and pool the embryos? Because at the end of the day, the clock is ticking against time, and the ovaries are also racing ahead of her age. Do you think, with the newer protocol of dual stimulation, a lot of the units are using, where would you, or what is your practice, and what is evidence? Where would you sort of come to strike a balance? Because patients are wanting a baby at that age, and they're very, very desperate. So how do you take that?
Yeah, so it's a very difficult one, because I know fundamentally where my heart lies. I'm not in favor of dual stimulation because I find that stimulating, going through the simulation and egg pickup is the most morbid part of any IVF, vis-a-vis egg transfers. So to me, what I always envisaged was you do one cycle, you transfer, because these are typically one of those only few patients whom you can do a fresh transfer. Otherwise, we are getting defensive all the time now, as you would agree. And anybody who's got 7, 8 oocytes or 10, we start going towards freezing this way or that way. But poor responder is one of those cases where you just want to give them that chance. And this is one of those cases where we don't know who will conceive, but we are denying them and we hold them back. And again, you are actually going to the whole stimulation and egg pickup, which is again double for the patient. So, and what are we gaining 2-3 weeks? That's where But I have heard the argument because there was a debate on this initially this year again, and I found both sides convincing, but of course my heart was towards against Duostim. So they gave an argument that they had a very high dropout rate for the lady who would, you just do one cycle in a thing and they never come back. And they have given a split of, why they don't come back and so on. 50% was financial, but 50% was psychological and so on. So that was an argument given that, dropout rate is so high that they will not come back for the second cycle. I am not very sure about that argument because it's up to us as counselors, we spend more time and get them back as early as the next cycle or one more cycle later. But medically speaking, the studies, of course, wisdom study and so on has shown no advantage of, getting a higher cumulative live birth. There would be, and in fact, the time to pregnancy was lower in single stimulation. They didn't have a higher, because you would have so many patients conceiving in the control arm, whereas Duostim, you are denying them that chance and you are pushing them to a freeze-all cycle. So my heart is still for one per cycle. Evidence is definitely not in favor of Duostim, but the argument given of higher dropout rates and, that is something that I find it hard to believe, but I would like to know what you feel in your practice.
Yes. So I totally agree, this group of patients, it's easy to say, yeah, it's how you convince them and get them back, but finance is something which holds them back. So my experience is different, and it's not what I would say, because coming from a government hospital or a public hospital where we're giving a dual stim at the same rate as a single cycle. So we are able to sort of, that's basically the financial gain that we, or a financial trick that we get, because if she is, and we did it as kind of a trial or a thesis, and then we found, yeah, the luteal phase in these women, and we are following a very strict criteria. So we are, it's a randomized trial, and we are looking at both the arms, and we found, yes, given the benefits. So our randomization is not, apples to oranges. We're actually looking at two protocols for LH suppression, i.e. the oral versus the antagonist, and that's the way it went. So it is an unblinded randomized trials, and where we realized that, yeah, we had more takers because this woman is just spending money for one. So therefore, I cannot say that what is my wisdom could be extrapolated in the real world. But this is how we wanted to explore how dual stimulation and understand every bit of it. And we found, yeah, the luteal phase in these women is, in majority of them, the luteal support gave us a good cohort. And of course, the impediment is that, yeah, I'm forced to do a freeze all, which again pushes the cost if I was in a private or in even but in my marginalized kind of a society where I have, and I'm not charging much on the freeze, and I think it's working. But in the real world, that doesn't happen. But yes, certainly I would agree that the dropouts are far too, no matter how good you counsel, even finances, the moment is so emotionally drained that it's hard for them to get back. So there, it is just, I would say, let's see when more data comes, and then we could say on. But certainly, I'm not doing a PGTN on these embryos, so I can't say that I'm creating a luteal phase cohort, which is definitely euploid, as against Dobaldi's group, or for that matter, a lot of European cohorts where they have looked at the ploidies.
Yeah.
So mine is a real world scenario where I don't have a facility to test the blastocysts. That's where I think maybe a bottleneck for my sort of data that I can sort of share.
Yeah, I think the Ubaldi's group also did claim that they were not charging extra for the second cycle, but that discussion in their article was it was not in the method section or anywhere else. They had just hidden it in the discussion. They had just mentioned it that they are not charging. So that kind of becomes a difficult thing, scientifically you would like, monetarily it will make a difference, but in your setting you can understand, but real world it will be charged and,
yeah, you're right, because at the end of the day, but then I know that how marginally low will one get between a dual stim and a back-to-back cycle. I think the cost would not be very different, because at the end of the day, you're giving her a full cycle of Galactrofen. Your cost may not differ, but yeah, you're holding capacity 15%. To hold the patient. the client would definitely totally improve. So I think that was real, experience that is there. Maybe we publish this data and get wiser. So I think it's been really interesting, and I think we could go on. But before we sort of wind up, because I think I realized we've already talked 45 minutes, we've been on it, and we could go on. So, before I really come to a close, I would just want to hear what would be your sort of and I talk this to all my, guests on two aspects. What do you look at our field? Because all the youngsters feel that this is a subspecialty to take in, as you compare to 20, 25 years back when we took up to the specialty, where there were very few people beginning to take, or at least in the academia. But today, every postgraduate from MD feels that's the panacea, that's the ultimate I would reach in, and that's a subspecialty. Where do you see the subspecialty of reproductive medicine heading, vis-a-vis urogyn or fetal medicine or gynae onco? So what is your understanding and maybe your pearls of wisdom to the youngsters? How should you take this?
So as you know that this is probably a hot subspecialty, I would call it, for the OBGYN fraternity, for many reasons. But I think one of the main attraction, I would say you would agree, is with better work-life balance. And of course, it's a lot of monetarily, of course, it's much more paying. It's a low risk, high return kind of thing. Whereas, some other specialties, it's slightly different. But I think you and me would agree on this, that if you are looking at this specialty, take it the full package, that is, as you and me are teaching our students, they need to be good in other areas as well, the endoscopy, handling early pregnancy and so on and so forth, handling the male. The whole package has to be there. It's not only about IVF, it's about treating the couple. And I think we should take pride in those couples who are conceiving naturally or non-ART. It's not about, every patient walks in and we end up doing IVF. I think a unit should be probably gauged in terms of how many of us could leave the patient alone. I think you and me agree, Aberdeen and whatever experiences, how many of us, so many of the patients actually conceive spontaneously. And that's the way. And IVF is just a small subset of our whatever we are doing. We have to look at the bigger picture, get trained in endoscopy, be the complete reproductive medicine and surgery specialist as we have envisaged in this course. Just IVF, just banking on just a small subset of the whole specialty is not a good idea. We need to work hard. And I would and you would agree that they need to be better informed. There are just too many changes, too many things come every year in this field, and we need to be responsible, clinicians. We need to be very careful, because whatever we are doing, it's not about one person. Now it's transgenerational. It just goes to the next level. Any tinkering we do in the lab has huge implication for generations to come. So we have a big responsibility, and as a country, we are going to grow. We are already on the pathway, and things are going to get better here. This is the place to be. It's been great here practicing. And I think we just take it on ourselves to practice the right way, the ethical way, transparent way, and learn all the skill sets that are required to become a good, safe reproductive medicine specialist. Just don't restrict only on IVF. That's just one part of it. That would be my, probably a take-home message. Yeah.
Right. Thank you, Mohan. I think you really pointed out very rightly. In this specialty, this is a low-hanging fruit, but be ethical, be transparent, and I think that's the way forward. There will be many gizmos coming, there'll be many more techniques, but if you have your ethics in place, you will always be a winner, at least in this field. Thank you so much. I think it's been a pleasure to have you, Mohan. I think this podcast would really, really inspire many young clinicians, researchers, and our junior colleagues to sort of look to how we take this specialty to greater heights. Thank you very much once again.
Thank you, Dr. Nen. It was a pleasure having you here, and we had a good, I think, discussion, and I really liked it because I was a little stressed. I thought it would be like a vivas, but you made it pretty.
No. We put you at ease and we look at
Yeah, it was fantastic.
Thank you so much.